Hi, Dr. Watts. Thank you for joining us here today to discuss Rotarex. Appreciate you taking the time. Before we get started, can you tell me a little bit about yourself and your PAD practice?
Yeah, no, happy to be here. So I'm Mike Watts. I'm an interventional radiologist, and I work with Atlantic Medical Imaging in basically the southern half of New Jersey. Um, we work out of both hospital-based and outpatient-based sites of service. We run three outpatient-based labs and cover three different hospital systems between 10 interventional radiologists and 5 vascular surgeons. Um, Basically concentrating on limb salvage, wound care, and complex PAD.
So, safe to say you have a lot of experience in this space. What has been your experience with Rotarex? How long have you been using it, and when did you adopt it into your algorithm?
So I was a pretty early adopter. I've been using it for a couple of years now. I was aware of it as it was being used in Europe, and I knew when it was on its way over and going to be available to the United States. And people I knew who were using it there had nothing but great things to say about it. So I knew when it came over that I wanted to try it, and it really filled a great niche that I was looking for. So as soon as it was available to me, I started. I was probably one of the first ones in the region.
How do you know when it's the right case for Rotarex? Is there a specific signal that you're looking for, something you see in the angiogram? Kind of talk me through when you know you're going to pull it.
Yeah. So basically every case, I kind of have an idea of what it is I'm going to be treating as far as anatomically, based on non-invasive imaging, but it really comes down to not just the angiogram and the runoff, but also the intravascular ultrasound, the IVUS images. Basically at this point, having used Rotarex so much, any in-stent restenosis, I'm going to use Rotarex. The real reason for that is how heterogeneous the material inside that ISR can be, whether it's neointimal hyperplasia or chronic thrombus, and there's almost always some sort of acute thrombus in there. And previously we had used Jetstream, which was a bigger device, which was a little bit more onerous to use, and the aspiration wasn't as good as Rotarex was, so I was never very happy with that. The filter basket was always pretty full. I switched pretty quickly after a lot of experience with that to using laser for in-stent restenosis. But as much as good of a job it did with the ISR, also we would find a lot of downstream emboli, whether in the filter basket or in a tibial artery, unfortunately. So any ISR I'm using Rotarex, the aspiration is excellent. It's one of those just situations where the first 10 or 15 ISR cases I did the Rotarex, I had a filter and never had anything in it. So now I can use it pretty safely without a filter and very confidently. If we're running through a long segment of ISR, which is occlusive, what we'll generally see is that stent column basically contracting around the Rotarex. That aspiration is so good. And not only is that kind of an indication of the strength of the aspiration, but also it is kind of pulling those stents, a little bit closer in and maybe getting more treatment of the neointimal hyperplasia that's there. So that's been a really great place for using the device. The intravascular ultrasound, like I said, anything that looks like there's any occlusion, CTO, or stenosis that has some sort of acute or subacute material in it, so thrombus, subacute thrombus, we're going to use Rotarex again because we just want to be as safe as possible. So never want to have anything fly downstream after we use a different atherectomy device or use just some sort of angioplasty. So we're always very careful with anything that looks like it's not well adhered to the wall or some kind of thrombotic occlusion or stenosis. CTOs that are crossed, again, intraluminally, basically any intraluminal cross that's not extremely calcified, so anything that's kind of fibrous or a chronic, not terribly calcified native CTO. We're using it for bypass graft thrombectomies. And what I do find for synthetic grafts is when you get the proximal and distal anastomosis, those things can get really, really tight with fibrotic scarring, and they really don't respond well to angioplasty. We're using a lot of specialty angioplasty, scoring angioplasty, serration angioplasty. But actually having the ability to use the Rotarex and kind of cut through some of that fibrous tissue and aspirate it out has also been great. So, there are a lot of things I'm using. It's kind of my go-to device for any vessel that's big enough, and anytime that I'm, that I know that I'm intraluminal, I'm using it whether I'm antegrade or whether I'm up and over retrograde. It really doesn't affect the function of the device for me.
Thank you. You talked about a wide variety of uses for Rotarex and mixed morphologies that you use it in. So is there ever a time that you would not recommend using Rotarex?
Sure. So, I found the device to be safe, but not necessarily as effective in like heavy intraluminal calcium or just very calcified lesions. So, if there's some calcified lesion with something mixed there, maybe it's worth doing, but I often don't do that. And then if I'm crossing a CTO and I'm always using IVUS, like I said, if I'm subintimal, I'm not going to use it. Certainly don't want to get any tissue flap or anything kind of caught in the device. So I avoid it there. And then smaller vessels, anywhere down, below the very proximal tibials, again with IVUS, not using it. So you can probably find a better device for calcification. I'm not using it subintimal, and I'm not using it in smaller vessels, but that's basically it.
That's helpful to know. So can you share a little bit about your technique when you're operating it? You mentioned you previously used a filter. Is that something that you're still continuing to do? How many passes do you typically take? And then do you have a preference on which device size, whether that's 6 or 8 French?
Sure. So a lot to kind of unpack there. So it is very, very, very rare for me to use a filter. It's funny because I would say if we had this conversation last week, I'd say I've gone months without using a filter, though I use the device multiple times a week, but actually used 2 filters this week. And the reason that I did, they're both ISR and patient who had stents for quite some time, but had a recent change in their symptoms. So new onset of kind of ischemic symptoms in chronic stent ISR. So I thought just clinically that there was going to be some mixed morphology, some more acute or subacute thrombus associated with this more chronic neointimal hyperplasia. So both of these cases, I put a filter down, ran the Rotarex through, was able to get excellent clearance of the stents and excellent flow, and in neither of them was there anything in the filter, which really is what I'm expecting. I really don't ever see anything in that filter. So I used it twice just out of abundance of caution this week, and neither was probably necessary in the long run. As far as my technique goes, I also previously was much more of a user of the Phoenix device, and I still enjoy it. But what I've always done in that device, which is kind of like a cut and clear device, as the Rotarex kind of is, but the Rotarex has active aspiration where that clearly doesn't. I like to do what I kind of call 2 steps forward, 1 step back. So as I'm engaging a lesion or I'm inside a occluded or stenotic stent, I will push the device very slowly forward, maybe 2 centimeters, and then pull it back 1 centimeter and just kind of let it rest for a split second, and then push forward 2 centimeters and then pull back. And I'm doing that, hoping that as we're clearing some of this occlusion, blood is coming from upstream and kind of more or less washing out what it is that I'm cutting, and kind of giving the device a little bit of a chance to kind of lubricate with that blood and then mix with any debris and pull it out. So I do that constantly with every time I use the device, have great results. And if I have a long segment of occlusion, maybe some of these SFA, FemPop stent occlusions are 25, 30 centimeters long, I'll do one pass all the way down till maybe a centimeter from the end, and I'll keep it running as I move it back to the origin, and then I'll do a second pass all the way down through. So I kind of, at least in my mind, I'm leaving that distal cap in place, so I get 2 good shots to clear out anything without any concern for distal embolization. And after I go through the second time, I'll take that distal cap with me and get that through and through flow, which we always get. So I tend to stick with the 6 French device. It really does a great job. Our practice of putting larger sheaths in critical limb ischemia patients has really significantly decreased. That the 7 French angiojet used to be what we would use a larger sheath for, and now clearly we don't have to because the 6 French Rotarex. I would be happy to use the 8 French if I think it was necessary, but the luminal gain that you're able to get with just the 6 French device really doesn't lend itself to needing the larger device very much.
Thank you. So what advice would you tell a physician that is considering bringing Rotarex into practice?
Sure. I think the most important part is to really prepare yourself and set yourself up for success, meaning know exactly what the lesion you're treating looks like, know exactly what your cross kind of anatomy is, where you are. So use IVUS, and then make sure that you already kind of have an idea of what you're hoping to accomplish by using the device. So kind of a mental checklist. Is this safe? Meaning, am I in through the lumen? Are these vessels appropriate sized? Is this going to be effective? Is this relatively acute or subacute, thrombotic, fibrous? Or is that the type of morphology we're dealing with as opposed to calcified? Do I have good sheath support? I tend to use a pretty stiff up and over sheath, and I think that gives the opportunity to kind of flex the bifurcation a little bit and give yourself a nice round path as you kind of go up and over the bifurcation. So it's a mechanical device, so you do need to make sure that you are well supported, as opposed to something like a small laser fiber that you're just tracking over the wire. And then what are we hoping to accomplish? Do we want to reestablish flow through an occluded stent? That's great. Sure, that's going to happen. You're going to have a great response to that. Is it a native SFA occlusion? Is it a thrombosed synthetic bypass graft? What do you expect to kind of get out of it? And then prepare yourself for that, and try it on some relatively straightforward devices. Have your rep support there. I've been lucky enough to have outstanding rep support, though clearly having used dozens and dozens and dozens of these over the past couple of years, I don't need the support there so much, but it's always available. And I have introduced the device to a lot of other operators, and they have always had the support they need from the BD support team. So just they know what they're doing. They understand the device. They've seen probably hundreds of cases, so rely on them. But it's not a difficult device to use. It's not a difficult device to understand, and the results are really like I said, kind of in the introduction. It's filled a niche, which is this kind of very safe and effective way to clear mixed morphology plaque, which otherwise is likely to shower, and it just has a great cutting and aspiration ability. So you're going to be surprised in a very positive way once you start using it.
Really great insight, Dr. Watts. Any additional comments that you'd like to share, or any topics that we didn't discuss about Rotarex that you think are important?
I didn't talk much about thrombectomy. That's not a huge part of my outpatient practice, but we have used that in kind of the inpatient setting. again, mostly in thrombotic occlusions in known PAD or CLI patients. So like in situ thrombosis from plaque rupture, or something that's happened, kind of immediately after a stent occlusion. It has definitely saved us some overnight thrombolysis drips, which is very helpful in patients who are either older or at risk for other complications from thrombolysis. So it's definitely helpful in kind of this arterial one-day thrombectomy idea rather than doing the overnight drip. It can really save that sometimes, because the thrombectomy is excellent, and if it's in a setting of diseased vessels from a PAD perspective, it will treat those and prevent that from thrombosing again in the future. So that's a small part of my practice with it, but I know there are other people in my practice and neighboring practices who use it a lot more in the hospital for kind of acute thrombectomy indications that I use it a little bit less for, but have successfully in the past.